Welcome to the Menopause Hour, your go-to source for answers to your burning menopause questions, the ones you won't get from your OBGYN. Brought to you by Winona, where menopause care is made easy. Download our free Winona community app where thousands of women connect and access exclusive content, expert-led courses, exciting events, and more. It's time to take the guesswork out of your hormonal journey.
Hello, everyone, and welcome to another one of our live Q&As. Well, it's usually with our Winona doctors, but today it's with our Winona doctor. We have Dr. Green here with us, and I know a lot of you have seen his face and you know about Dr. Green, so it's always really exciting when we get to have an event and kind of hear from him and hear his thoughts. But just want to say I am so glad that you are here and that you made the time to be here. If you don't know as well, I always first introduce myself. I'm Maddie. I'm the community manager here, so you'll probably see me around in the app as well. But if you want to, you can go ahead and start dropping any questions you might have for Dr. Green in the chat. So at the bottom of the screen, there should be a chat button. You can click that and start dropping your questions in there. We often get a lot, so I always tell people to go ahead and get them in there as quickly as possible, and we'll get to them kind of in the order that they come. So ask anything in there, and we'll jump into it. But again, so glad you're here. And Dr. Green, I'll kind of pass it over to you to do a little intro of who you are, and then we'll jump to the questions.
So my name is Mike Green. I'm an OBGYN. I am the Chief Medical Officer of Winona, and super glad to be here. So my story, I actually did a family practice residency, fell in love with women's health, really loved delivering babies, told I had good surgical hands, and so spent most of my career doing full-scale OBGYN. It has been 1.5 years or so since we've launched, and we started Winona because there was a big hole in that women were having a hard time, and still are, getting hormone replacement therapy from their regular doctors. There's just not a lot of education. People are misinformed. Unfortunately, women go in finding up classic signs that can be treated really easily with HRT, and they leave telling them, but the doctor's telling them nothing's wrong with them. And so fortunately, we have Winona, which we created to try and help with that, and get access to people from doctors that, really specialize in the menopause transition and doing things safely and appropriately, really according to the most current standard of care. So that's how we do here at Winona. There's always all kinds of questions about this because unfortunately there's really a ton of misinformation out there, and has been for a long time. And even now, as a pendulum is swinging back, there's crazy stuff out there, and people get really confused. It's women, that's the way it is. But there's doctors, there's bloggers, there's all kinds of craziness out there that gives bad information. So this is a place to try and help clear things up, explain things, anything from, how does this stuff work, to what can I expect, to what are side effects, or what are the origin stories of Winona, whatever you want. I'm happy to talk about it. So go ahead and put your questions up, because otherwise you're going to just hear me ranting and talking, and that's no fun. So you'll hear me ranting and talking to answer your questions at least. Hopefully we got some to get started. Let's get to them.
We do. We've got a bunch of questions today. And I did just want to say too, so I know that we are using a little bit of a new platform. So this might be a new platform for some of you for these live Q&As. So just so you know, I see a few of you have been raising your hands. Go ahead and drop those questions in the comments, because we won't be able to call on you specifically. But if you drop those questions in the comments, we'll get to them as quick as possible. But so our first question tonight is from Brittany. And Brittany says, I just started the 50/50 cream. Will this mess with my cycle?
So long term, it will. Hormone replacement therapy typically does not affect the cycle, either for better or for worse. Sometimes it'll make things a little bit lighter, but in general, it shouldn't make your bleeding abnormal. It shouldn't stop your periods. It's not going to particularly fix a problem if you have bleeding problems. It's kind of one of the things HRT doesn't do a good job of. On the other hand, it's not going to mess with your cycles. That's long term. Now, sometimes for some people, when they first start HRT, there can be some abnormal bleeding in the first month or two. So sometimes it'll trigger an extra period or trigger a period earlier, give you a little spotting. And that can happen. It usually doesn't, but it does happen from time to time. So in the first month or two, don't be alarmed if you do have some irregular bleeding, but things should get back on track after that. And really, if you have abnormal bleeding beyond the 3-month mark, you consider that abnormal enough that you don't think it's from the HRT, and we really want you to be checked to make sure there isn't some other problem going on. That has nothing to do with the medication.
Absolutely. And our next question is, how do you start the process of HRT? Is it with blood work?
So it turns out that blood work is not helpful for either figuring out how to start HRT or managing HRT once it's started. It's just one of those things where it doesn't really work well. The problem is that hormones fluctuate all over the place, day to day and even hour to hour. It can be affected by all kinds of stuff. So if you check a set of blood work right now, and then you check it a couple hours later, it may look complete. And this is kind of what I was talking about sort of at the very beginning, is that it's not uncommon for someone to come in to their doctor with all these symptoms. Their doctor's well-meaning, but isn't well-educated or well-versed on HRT, and they order blood work that's not particularly helpful. The blood work happens to come back normal, which doesn't mean to be thin. And they're told, oh, it's not your hormones. And then they end up finding their way to us, and we know that that's not really the right way to figure it out. And we start HRT, and people do better because actually it was their hormones. So you really don't need blood work. And if you look at ACOG, the American College of Obstetrics and Gynecology, which is sort of our governing body as OBGYNs, and the Menopause Society, those are kind of the two big groups that kind of speak expert advice towards menopause and treatment and menopause transition. They both say the same thing, that just labs are just not helpful, they're not useful, basically a waste of time and money. So how do we do this? Well, first, we need to understand more about you. So we ask you questions that help us understand symptoms that you're having and your general health history. We want to make sure that HRT is safe for you. That's really the most important thing, honestly. We don't want to do anything that's going to cause you harm or put you at risk. So, if I make your hot flashes go away, but I kill you, I haven't done you any good. It's trying to make it doesn't happen. So we ask these questions. And the interesting thing is, we don't really need as much information as you would think. Maddie, stop me if I start going too much.
No, I always think it's great. I think this is good.
When I first designed this, honestly, I did a poor job. And because I was used to the office. And what happens when you go to the doctor for the first time? They give you this giant book of stuff to fill out, right? You sit in the waiting room and you try and fill it out, and then you don't get it done. You wait in the room and you're trying to get it on. There's this giant information. And the truth is, probably 95% of that information is not particularly helpful for what you're being seen for, right? Like, really doesn't matter if you broke your ankle in the 3rd grade as far as managing your hormone replacement therapy. So when I first designed this, I asked way too many questions. And so I was sort of coached, just ask everything you need to know, but nothing you don't need to know. And so we really worked on that. But one, to get the onboarding as easy as possible to keep it safe. So it's really not that many questions, but it's everything I need to know to safely prescribe and to prescribe a pill. So we look at that and make sure it's safe. And then I developed an algorithm. It took about the first 1,000 patients or so to really get this thing down. And basically what I did was patient would onboard, and I'd decide, okay, this is what I want to give them. And then I'd stop and I'd think, what's firing in my brain that made me make that choice? And I tried to really tease it out. And using that, I developed an algorithm so that now, we have this algorithm that recommends a treatment protocol for you. And it works quite well. So you look at that, you say, yeah, that sounds like a good idea. And you submit to the doctor. The doctor looks it over. And sometimes they change that because they say, you know what? I don't really agree with the algorithm. There's this thing or that thing. But most of the time it works pretty well. Then based on your symptoms, your medical history, we come up with the treatment plan and the dosing regimen, and we send that to you. And then it takes about three months, maybe a little bit less to really know whether this is the right dose of my treatment for you. And so we check in and say, how's it going? And if everything's going great, we continue. And if it's not, then we, adjust it and tweak it until we get it just right. So we really try and personalize this for your individual body because everybody responds to it differently. So that's a very long answer to a very short question. I hope that addresses everything for you.
I mean, I think, at least for my end too, I think it's really helpful to hear all of that background, and like how much really care and thought goes into the whole process of making sure it's safe. And then, I don't know, I think that's also, can be reassuring to kind of know a little bit about what the process is going to look like, of like what this is going to look like. So I think it's great. I think that's a great answer and details to go into. And our next question is it's related a little bit to what you were talking about as well, but it's kind of on the other end. They're wondering, how long can HRT be used safely and is recommended to be used for?
Sorry, how long? I missed the very first part of that. How long
can HRT be used safely?
Right. Yeah, that's a really good question. And that answer is changing as far as what the expert opinions are. So, way back in the day when I first got out of residency, so it's back in 99, we thought everybody should be on HRT. That was a vitamin. Someone come in 90 years old, oh, you're not on HRT, we give them HRT. Oh. And it turned out that was a mistake. And so then pendulum kind of swung the other way. It's like, oh, we've got to minimize this and give you the smallest dose for the shortest amount of time to try and keep this as safe as possible. And that sort of became the way people did it. Now there's more and more data coming out there. There's actually long-term health benefits to HRT beyond just symptom control. Things like decreasing your risk of heart attack, other cardiovascular events, decreasing your risk of osteoporosis, decreasing your risk of certain cancers. There's a lot of benefits of HRT beyond just symptom control. And so the sort of thinking is changing now, and that now we're thinking that it's much more appropriate to keep people on HRT for longer periods of time. And some people are saying really keeping them on for a lifetime. In fact, there was just a big article published I believe it was in the Grey Journal, which is our premier OGN journal. It was talking about, how safe it is to keep people on HRT after 65. So the bottom line is, we're not really sure. There isn't a hard number. So it's not like, oh, you got 5 years of HRT and then we're cutting you off. So it doesn't work out. It's really individualized again. And so as long as it's treating symptoms, clearly it's good to stay on. Some people are advocating that it may be something that you want to stay on for life as long as you don't develop certain medical problems or you don't develop side effects to it. And that's really a sort of an individual decision. But certainly the average patient is on HRT for about 5 years. If it's something that you don't want to be on long term, then I suggest that every few years, you try going off of it and see how you feel. And if you feel the same, then it may be something that you don't want to continue. If your symptoms come back, go back on and get those symptoms under control. Now, do yourself a favor and don't do that like just before your kid's wedding or something. But do it. It's not a big stressful time. But that's a reasonable way to decide. But again, I know Dr. Kat Brown, our medical director, she was on, and she usually has her kid's birthday today. So she's taking a break, but which is important. Family comes first. So she's made the right choice. But she'd tell you, you can pry this up out of my cold dead hands. She's planning on being on HRT forever.
I love that you brought that up, Dr. Green. I was about to mention it as well. So you can tell for some of you that we've gotten some of these questions and gone through them. So we've heard some of the answers before. But that's great because, I think that means that, these are questions that other women are asking and want to know. And so these are very natural and important questions to ask. But our next question is from Stacy. And Stacy is wanting to know, how do you know what's better, the cream, the pill form, or the patch?
So the truth is they all work well. There's some theoretical reasons why the cream or the patch may be a little bit safer than the pills. But the truth is the difference is pretty small. That'll teach me for drinking soda rather than water. And for most people, that difference isn't enough to be a huge factor. But if you want to know what's the absolute safest, it's going to be either the pills or the patch because they're absorbed to the skin rather than through gut. And so you bypass what's called first pass metabolism. In other words, when you take a pill, it has to go through your intestines, through your liver, where it gets broken down, and then it gets dispersed to the rest of the body. When you use it through the skin, like a patch or a cream, it gets absorbed through the skin and goes directly into the circulation. It eventually gets broken down by the liver, but it doesn't all go there all at once. And so there's some theoretical reasons why that decreases some risk. But again, those differences are pretty small for most people. So really, it kind of comes down to personal preference and cost. So if you are needing estrogen or progesterone, the cream is going to be the most cost-effective, it's the least expensive. The patch is the most expensive, and the pills are close to the cream, a little bit more expensive, but about the same. So that's one factor. But you also want to think about, what are you going to be most compliant with? What are you going to be able to use? Because the stuff doesn't work if you don't use it, right? That's my joke when people ask about condoms. It's like, yeah, condoms are great, except they don't work when they're sitting in the cupboard, which is why people get pregnant with condoms. And it's the same with any medicine. When they're just sitting in your nightstand or in your medicine cabinet and you forget to take them, it's not going to help. So you kind of think about, for your personal situation, what's going to be the easiest for you to use and, the better to tolerate. For some people, taking a pill, they're already taking pills. That's easy. They just throw it in their pill container with the rest of their stuff, and it's super easy. Other people, they don't like taking pills, and the cream can be really convenient. Just rub it on, squirt it on your forearm. You just do this, do that once a day, easy peasy. Other people say, well, gee, the patch, I only have to deal with twice a week, so that's more convenient for me. And then some people say, well, I don't want to have to wear a patch all the time, or, I'm a competitive swimmer, or I'm in the sauna all the time. Patch may not be a good idea. Or it's the summer in the deep south and I work outside. I'm going to sweat a lot, and the patch may not be a great idea. So all these things kind of enter into it. They all work great. They're all pretty much reasonable choices for most people. And so it comes down to personal preference.
And our next question tonight is from Angel. And Angel is wondering, is it normal to continuously bleed throughout, she says, throughout my now 2 months of treatment?
So no, it's not normal. As I said before, the first couple of months can throw off your period. But 2 months of bleeding every day, that's not okay. And that's not something that you should tolerate. So you really want to message your doctor. There's some things we can do to try to get the bleeding stopped. If this continues and nearly beyond the 3-month mark, it may be something going on. It's a polyp or a fibroid that's bleeding that's not from the HRT, and it's something that you're going to need to get a physical exam or a ultrasound for. But there's some stuff we can do to try to help stop bleeding, and then hopefully that'll come back. So I would message your doctor. That's not something that you should with 2 months of bleeding. That's not okay. So you definitely want to message your doctor and work with your doctor to get this under control.
And our next question is from Melissa. Melissa says, I'm 40 years old and I've been reading about some side effects that people have been having from weight gain. So they've also seen some about anxiety. So I'm wondering if this is a good idea for me to start in menopause. She says, I also have bipolar and is just wondering if there's any side effects that kind of come from that, and that she's also on a medication that stops her periods. And she's wondering if she'll still spot bleed anyway. So if you need to go over that again, I can. That was a little, I know this dream head.
So basically, most people long-term lose weight with HRT, particularly menopausal weight. So, if you've been heavy your whole life, it's probably not going to fix that. But if all of a sudden you hit a certain age and, oh my gosh, the pounds are sticking on, this can help reverse that. It can also change the way the fat is deposited. So as the estrogen levels decrease, that tends to go towards the central body, and that can help, replacing that can help reverse that. So HRT actually should help you lose weight in the long run. It should not cause weight gain. Now, in the first couple of months, sometimes HRT can cause some water retention and some bloating, but that should be temporary now, and that'll go away with time. With weight gain, I forgot. Oh, anxiety. HRT often actually helps anxiety as well. So occasionally the DHEA can trigger some mood changes. I have seen that, but that's fairly unusual. In general, anxiety is one of the symptoms of the menopause transition, and HRT can help improve that. So for the most part, it shouldn't adversely affect your mental health. If anything, it should make it better. Now, I understand with bipolar, you want to be careful. You don't want something to kind of throw you over. And so in your case, maybe you want to start the estrogen progesterone first and add on the DHEA down the road a little bit, because DHEA is the one that could sometimes throw things off. So that might not be a bad way to do it. In your case, normally I advocate starting them all together. But again, everyone is a little bit individual, and this may be a better way for you to start it. There was another part that I lost.
She was also, she was wondering about if there was any kind of, effects with mental health. But I think you covered that with the bipolar. And then she's just wondering, she's also on a medication that stops her periods, but she's wondering if she'll spot bleed anyway.
So as we've heard a couple times already, short tongue tonight, sometimes it can make you spot a little bit, or unfortunately in Angel's case, which is unusual, bleed continuously. But for most people, it doesn't do that. But in the first month or two, sometimes you may have a little bit of bleeding. But once you get past that, it should not affect your menses. So if you're on medicine that's successfully stopping your periods, this should not mess with that. Then you should be okay.
Absolutely. And our next question is from Irene. And this plays a little bit over what we were talking about between, the cream, the pill form, and the patch. But she says that she's taking the pill form right now at night. But she's heard a few women that have mentioned that maybe taking the pills is a health risk. And so she's wondering if that's true and why taking the pills would be a health risk, if so, over taking the patch.
So I kind of touched on this already, and it has to do with that first pass metabolism. And the thing is, your risk of getting a blood clot or something like that is a little bit higher with pills than it is with patches or creams. For most people, that difference is fairly insignificant. And the way I like to say it is, look, if I told you were twice as likely to win the lottery, you know what? You're still not winning the lottery. Sorry. Okay. It's just, it's this idea of absolute versus relative risk. So when you're twice as likely for something incredibly unlikely to happen, it's still kind of bad likely. And so these ratios, these odds, these risks are sometimes hard to understand, because are they talking about relative risk or absolute risk? In this case, you are more likely to have a very rare event, but it's still very rare for it to happen. So unless you have some kind of underlying condition that already puts you at risk to these things, the pills are very safe. And I can tell you right now, my wife is on those. So, she's tried all of our stuff. Right now she's kind of set all the pills. But obviously if I thought, these pills are risky, I don't. So I don't know what and I love my wife, so I'm not trying to knock her off. So.
Good to add that in there. Slip that right in.
Just having life insurance. Joking. But, so obviously if I think it's safe, not for my wife. Now, unless there's some specific medical condition, I'll talk to your doctor about it. But in general, the pills are very safe.
Right. And our next question is from Melissa. And Melissa says, hi all. She says, I've had facial hair since I've been in my early 30s. Will this help to alleviate that, or may it make it worse?
So it may or may not help alleviate it. If it's been since your early 30s, probably is could be age-old. The DHEA sometimes can make that worse for people. So if you're going to, opt not to do something, the DHEA would be the thing not to use. But estrogen progesterone should not make that worse. Some women develop increased hair, particularly facial hair, as a symptom of the menopause transition, or they do, HRT helps improve that. But if this sort of predates that, it may.
Absolutely. And our next question is from Sherilyn. And she says, I'm about to start an HRT cream in the vaginal cream. Will it help with vaginal dryness and itching?
So HRT cream does help with vaginal dryness and itching. It takes a while, and it works okay. The vaginal cream works extremely well and usually works very quickly. So vaginal cream is really dynamite for this. Within a couple of weeks, you should feel like a zillion times better. Now, occasionally, the first week or two, you might feel a little bit worse, and then you get better. And what's happening is that the estrogen is stimulating the vaginal tissues, including the glands of the vagina. And so as you go through the menopause transition, your estrogen levels are lowering, and the tissues in the vagina are very sensitive to estrogen. And so they start what's called atrophying or thinning out, becoming less active. And that's why you don't have the glands that are producing the normal discharge. So you have dryness and that itchiness. And sometimes people get pain or even tearing because the skin gets very thin. The estrogen cream replenishes the estrogen in the vaginal tissues and makes them healthy. Sometimes during that transition from not healthy to healthy, there can be some symptoms like increased itching or some funky discharge. And that's part of this transition of skin getting better. And it's kind of like, when you cut yourself and then it's healing and it's all itchy because it's healing, it's kind of a similar thing. As tissues are changing, the body sometimes doesn't like that. So there can be a week or two in this sort of transition period where things actually may be uncomfortable, which is annoying. But if you can get through that, it tends to get much, much better. The vaginal cream works really well.
And our next question is from Robin. And Robin is wondering, can HRT, DHEA help with symptoms from Hashimoto's thyroid syndrome?
So it's not going to help the Hashimoto's thyroid symptom specifically. Those are going to be helped by treating your thyroid. However, there's a lot of overlap between thyroid symptoms and symptoms in menopause transition. They're sometimes hard to tease out. So there may be some of this from your thyroid and some of it actually from the menopause symptoms. So you really want to do a two-pronged approach. You want to treat the thyroid, but you also want to treat the symptoms of menopause transition. So some of those symptoms that may be being attributed to your thyroid may actually be coming from menopause, and those symptoms are going to be incurred by the HRT.
And our next question is from Connie. And Connie says, I'm almost ready for my 10-week checkup. She says, I feel like I need more progesterone and more estrogen, but how do I know for sure?
So that's a great question. And the short answer is you really don't. But you can have clues. And so generally speaking, if the symptoms are getting better, but they're not completely better, or it hasn't touched it at all, then you probably need more. If everything's kind of good, then you probably no point messing with success. And so when you take the 10-week follow-up, one of the questions it's going to ask is, do you want to stay on the same dose? And it's also going to ask, how things are. So if the answer can be no, you're not sure, and then it'll ask you, what about the treatment? Is it working? And so that's where you want to put that in. You can also message your doctor beyond just the 10-week follow-up. So if you're not satisfied with the questions, and kind of back to sort of what I said at the very beginning, we try to design this minimalistically, which can sometimes be a little frustrating for me. But the idea is that you can always message us. So we don't want to bun people with questions they don't need to answer. But if the questions don't feel like you're asking enough, then answer the questions, but also send a message in addition to the questions to fill in the blanks so that we know what's going on. And so you're basically going to work with your doctor and say, I'm not sure whether I need dose change. This is what I'm experiencing. And then your doctor will say, well, based on your experience, what you're experiencing, this is what I recommend. And that's how the follow-up works. So something called shared decision-making. We don't expect you to be an expert in HRT, and we can't know what's going on with your body unless you tell us. So it's something that we need to work collaboratively and come up with a plan together that's going to best get you feeling best.
And we have a question from Danielle next. Danielle says, I'm almost 3 months in with my treatment. She's on the HRT cream and the DHEA. She says, my cycles started again, though. She says, spotting off and on all the time. She says, I'm in Perry and I'm 57. She said, I've dealt with fibroids for years. Are they just shedding at this point?
So if you're at the 3-month point and this is still happening, it may be something that you want to get evaluated for. HRT generally does not reactivate fibroids, but in some rare cases it can. Or there could be something else going on. There could be some inflammation. There could be a polyp. There's a whole host of things that can cause spotting. Sometimes what can happen is, let's say that you have some kind of inactive polyp that's just sort of sitting there and you don't know about it. Then the HRT can uncover that problem. So it doesn't necessarily cause a problem, but it can uncover a problem that's already there that you weren't noticing otherwise. And so that may be what's going on. So if it's really not improving at the 3-month mark, you really probably should see your local doctor to get a physical exam and probably ultrasound, just to see if there's something there beyond the HRT that's being spotting is our symptoms, sure.
We are tonight. I know we're getting a lot of that question.
That's different.
Well, this one's a little bit different. Melissa is wondering, does any of the HRT cause hair loss?
No. Again, this is not in the long run. So HRT for most people should actually improve the quality and the thickness of the hair. But that takes a long time. Here is a funny thing. Hair cycles, and the hair cycles are 4 to 6 months. So any hair treatment is always going to take 4 to 6 months before you see significant. There's this phenomenon called telogen effluvium. We call it TE because that's a big mouthful. And it has to do with the hair cycle. And sometimes when there's some kind of event, often hormonal, so it often happens pregnancy or childbirth. It can happen when you start birth control pills or when you start HRT. But it can also happen for other reasons. I know about this because before I became a doctor, because when I was 17, I got into this terrible car accident. Someone fell asleep on the road and it knocked me off a cliff. I was in the ICU and the hospital for months. Anyway, I was getting better and then all my hair started falling out. And so I was freaking out. My mom took me to a dermatologist and the dermatologist taught me about telogen. And so what happens is when there's some kind of an event, stress event, a hormonal event, all the hair sort of stops and it goes into this sort of shock state where it just stops cycling. And then that gets through that and it starts cycling again. And one of the parts that's the end cycle of hair is hair sheds. And so you constantly have this cycling, new hair growing, it matures, it pauses, and then it sheds. And so what happens is all the hair pauses, and then once things are better, it all starts shedding. And then eventually it goes back into a normal cycle, and all the hair follicles get into their own cycle again, and everything goes back to normal. But it's pretty freaking when it happens. And so that sometimes happens when we start HRT. It can happen within the first few months or even up to 6 months out. And all of a sudden your hair is shedding like crazy. It's scary. But what's happening is it's just this temporary kind of weird thing about hair. And typically on the other side of it, your hair grows thicker and more healthy. And you can see, that happened to me at 17. I'm 61. So I have a pretty decent head of hair for a 61-year-old guy. So it does come back. But that is, it can be scary when it happens.
Really? And our next question is from...
Here's a shameless pitch. We do have a minoxidil hair product. So HRT does help with or keep it better. So minoxidil is one of them. And so we have a hair serum. It's a 7%. It's a really strong prescription strength, much stronger. You can get over the counter and it works pretty well. So that's something else if you worry about thin hair.
Absolutely. And our next question is from Atusha, and she's wondering, can you use the estrogen face cream and an eye cream at the same time?
The estrogen face cream, it depends on the eye cream. So our estrogen face cream also has tretinoin. And so most likely your eye cream is okay to use, but it's something that you want to ask your doctor with the specific eye cream. And honestly, if you ask me right now, I'd have to look it up. So I'm not going to be able to be that helpful. But for the most eye creams should be compatible with our face cream. But I would ask specifically with the specific cream you're using to your Winona doctor.
And our next question is from Carrie. And Carrie says, I'll be starting the estriol 2 milligrams and progesterone 200 milligrams orally. She says, if I start having negative side effects from daily dosing, is it okay to drop to every other day of dosing?
So every other day is generally the wrong way to do that. It can cause side effects. So the better way to do it is to decrease the dose and take it every day. It's something you want to discuss with your doctor before you do. It can be a little frustrating sometimes for us, and that patients will write in saying, hey, I've been doing this. They didn't tell us what they were doing. It actually was Patriots. So please message your doctor. We're here for you. We want to help you. We want to keep everything safe. We want you to be successful. Very much so. That's what we do for a living. And so you're never a bother. So if you're finding that you're having side effects or you think you want to decrease your dose, let's see the doctor so that we can help you do it and do it safely. But so, for instance, in this case, you would maybe take half of the estradiol tablet every day rather than taking it every other day. And then for your refills, so you don't have to mess with breaking them in half, you can send it on Oreos. But that's kind of one strategy. But it's something that you want to do again, with your doctor helping you. Take advantage of us. It doesn't cost anything to mess with us. You're getting more credits.
Absolutely. I was going to say, I always give a little spiel at the end that your Winona doctors are there for you 24/7 in your patient portal. So like Dr. Green said, reach out to them. They definitely want to help in any way they can.
Our job is to keep everything safe for you, keep you out of trouble, and get you results. That's what we're here for. We're your ally in this.
I'm like, that's one of the cool parts about Winona as well, is you essentially have like a doctor in your pocket, like you don't have to go drive all the way into the office. Like I think that's one of the cool things as well. But our next question is from Carly. And Carly says, I have a question about the vaginal cream. My prescription says 0.02. And she says, Winona is the only company I've seen with that percentage. She says, everyone else I see is prescribing 0.1%. Can you explain the difference and why I only see that percentage with you guys?
So our cream is a compounded cream, which means that we're actually making it for you specifically in our compound pharmacy rather than a commercial product that's made some giant pharmaceutical manufacturer in India or China or somewhere. So this is made in either Twin Falls, Idaho, or in California. We have 2 pharmacies and sent to you. So this is the compound that our pharmacists came up with to be really kind of the most effective treatment. We've had really good success with it. And in fact, I've had patients that have either switched from a commercial estrogen cream or switched over and then come back. And people have seen it very happy with our compound.
Absolutely. And then we have a question from Robin. And Robin is wondering both does it, and if so, how does HRT help with PCOS?
So PCOS is kind of a funny thing. PCOS is fairly common in younger women. And it's something that people tend to sort of age out of. Part of it has to do with the way the ovaries behave as you go through the menopause transition. So there's a lot of people that are diagnosed with PCOS in their teens or 20s or even early 30s. Usually there's a cluster of things. It can be difficult to lose weight, facial hair, acne, infertility, abnormal periods. And so they're given this diagnosis appropriately of PCOS. They're given appropriate treatment for it. And then time goes on and PCOS sort of goes away because of the changes in hormones, but people sort of hold on to this diagnosis. So most women in the menopause transition that had PCOS move on. And for those people, HRT obviously isn't going to help or hurt because it's for the less common people, and there are some that still have their PCOS as they're going through the menopause transition. For those people, particularly if the androgenic part of it, that's the facial hair, the acne, and that kind of stuff, is sort of the predominant feature. DHEA is probably not something that you want to add as a condiculars. HRT itself is going to be fairly neutral. It's not going to treat the PCOS symptoms. It's not going to make them worse, but it is going to help cure menopause. But again, I think it's unusual to have somebody have both menopause transition and PCOS at the same time.
Absolutely. And our next question is from Connie. And Connie says, I'm 57. She says, I've had hot flashes, etc., but I got over it. She said, then I had an ablation, so no idea if I'm through menopause, but I think I am. She said, I started taking the HRT cream and pills for testosterone and for perhaps helping all over the body, foot, and joint pain. She says, I'm about a week in, but now I'm having hot flashes. Is that normal? She says, I feel like some of the pain may be lessening. I'm hopeful and also hoping this could help as I've had some trouble losing extra weight since menopause.
Yeah, it's normal and it's annoying. So it's one of the things, I mean, on the one hand, it's kind of good that it works this way, but it is fairly annoying. So what happens is the body doesn't like changes in hormones. In fact, that's why you get hot flashes. And the simplistic way to explain hot flashes is that the ovaries become less efficient. You're still trying to get hormone out, but instead of sort of getting it out nice and smoothly, it's spits and bursts of hormones. And he's like, quick bursts of hormones are what causes hot flashes. The body likes a steady state. It likes a nice stable thing. And so when you start HRT, there's this transition period. It takes about 3 weeks, give or take a week, to get those levels to the point where they're at what we call steady state. So your levels down here, and we want to get them up here. But to get there, we've got to do this. And that's the part the body doesn't want. And so in those first few heats, for some people that are more sensitive, they're going to get hot flashes and sort of worsening symptoms because the body isn't liking that change from down here to up here. And it's that change is causing hot flashes. That goes away once steady state's achieved, which takes a few weeks. It's annoying. The thing about HRT is that the side effects tend to happen early and then go away. And the benefits take a while, but then stick around. So, I mean, that's better, right? You wouldn't want it the other way around where the benefits, you get these benefits right away and then they go away and then the side effects show up. But it is kind of annoying. It's like I started this medicine and it's only making it worse. And then people quit and they never get to the point. So if you hang in there, this is going to get better, right? It's going to take a few months, unfortunately.
Absolutely. And our next question is from Shanna. And Shanna says, my dosage of the 50/50 cream was up to 7.5. She says, when should I feel some relief from the hot flashes? It's been 2 weeks, so this might be a little bit on kind of what you were just saying about it might take a little bit, but maybe there's some extra encouragement you can give her.
Yeah, so for dose changes, some people get relief right away, but 3 to 4 weeks is a good time period. For people that are starting initially, you really want to hang in there longer. But for people that are changing a dose, you expect to get some benefit from that dose change within a month. If not, it may mean that you need to go on this dose again. Unfortunately, some of this is trial and error because, again, we're listening to your body and we're treating this based on symptoms. And my philosophy is that I'd rather undertreat you and then have to kind of increase the dose to get things under control than overtreat you and whack you and with side effects or worse. And so, we're a little bit conservative and careful with the way we dose and increase dose. We'll do it incrementally because we don't want to cause problems. And we'd rather, unfortunately, have it take a little bit longer and get there gradually to a nice spot than go overshoot and cause you all kinds of problems. We don't want to hurt you, but that's the thing.
Definitely. And our next question is from Jana. And Jana says, I don't really have a lot of symptoms, but my main thing is debilitating. She says insanity, anxiety, low energy in the first few days of my period. Which therapy is most right for this one symptom?
So, if it's only happening the first few days of your menstrual cycle, I would start on a fairly low dose and see if that's enough to get things better. If not, then what you can do is you're on a low dose all the time. And just those few days, you can double the dose those few days. And that sometimes works really well at sort of minimizing the dose through a month and then kicking it up week. But you kind of need that baseline to start with to really get this control. But that would be one strategy. It may be that a low dose is going to be enough, but if it's not, you might be able to just boost it up those few days, those sort of bad days. And it's kind of a sort of a more novel way of doing it. Again, we really try and personalize this to your individual situation. So it's not a one-size-fits-all thing. So that's something that we could try.
Absolutely. Our next question is from Carly. And Carly says, I am taking DHEA and wonder if that's safe to use with NADs.
Sorry, with NAD?
NADs, yeah.
So, yeah, I don't know of any interaction between DHEA and NAD. NAD is given different ways. Generally, it's done, the most effective way is as an infusion. It's usually not done, but some people do use NAD as a subcutaneous injection. There are some NAD formulations that are done, so some under the tongue. And I think there's a nasal spray. I think that's just that some people are using. And NAD is something I've been actually thinking about trying myself. There isn't a whole lot of good studies behind it, but there's a lot of anecdotal evidence or anecdata, as Huberman likes to say. But there really shouldn't be any interaction between DHEA and EHC.
Absolutely. And our next question is from Carrie, and this is a little bit of a two-part question. She says, the first part is, there's a history of breast cancer in my family. Does HRT increase my risk? And her second half is, will HRT help my tendinitis? So that started in 2023, and now after a partial hysterectomy, it's become chronic all day, every day.
So let's start with the breast cancer. So a family history of breast cancer is not an issue for HRT unless you have a genetic marker for it, such as BRCA, or the Lynch syndrome. Here are some other ones. Those are the two most common. Even a close family history does not really preclude you from using HRT. And if you develop breast cancer, it's not going to be because of the HRT. I mean, 1 in 8 women are going to develop breast cancer. And so it's not going to keep you from developing breast cancer, but it's not going to increase your risk. If you have a BRCA or other genetic risk factor, it's still not absolutely contraindicated, but it's not something that we feel comfortable doing on this platform because there's some things that really require more intensive discussion and evaluation of history and getting data that we can't really do on a telehealth platform. And again, safety is the most important thing to us. And so, we'd rather, lose some business than really take risks because, again, the bottom line is we don't want to hurt anyone. So even if you have, say, BRCA, it doesn't mean you shouldn't take HRT, but it's really more involved in something that we feel comfortable. We just don't feel like we should do that well. But if it's just a family history without one of these genetic components, HRT is very safe for you. Tinnitus. So tinnitus or ringing in your ears can be a symptom of blood loss dosage. And if it is, HRT should help. People get tinnitus for all kinds of reasons. Men get tinnitus. So if it's tinnitus for some unrelated reason, HRT is going to help them. But from your history, considering that you sort of had it, it developed sort of later, then you had a hysterectomy, it got worse, that does clue me in to think that maybe this is hormonal. And in that case, HRT very well may help. And I guess time will tell. As you start the HRT, we'll see if it gets better. But we have had a lot of patients that have seen improvement with hormones.
Absolutely. And our next question is from Linda. It's a little bit more of a comment, but I'm guessing that she's has a little bit some questions in there as well. She says, I'm 53. I had tubal ligation when my twins were born. She says, but I went on birth control due to bad periods. She says that was 18 plus years ago. I'm starting the cream and DHEA tomorrow, and I'm most concerned about sleep issues and weight gain. So I guess she's wondering is this going to help with this?
Yes. I think there's a very good chance it'll help. So sleep issues in particular, HRT can help a lot, particularly, well, again, depending on what's driving sleep issues. So a lot of women get sleep problems. It's a very common symptom of the menopause transition. It can be because waking up with hot flashes, or you have to pee all the time, or it just can be the hormones themselves. And so adding back those hormones can help get you a good night's sleep. So I think I'm very bullish on the fact that this is going to help your sleep issues. There's a very good chance. Now, obviously, people have insomnia for other reasons. Again, men get insomnia. So it's not going to cure all insomnia, but it's a very common symptom that HRT helps. Sorry, what was the second one?
And then she's wondering about sleep issues and weight gain.
Weight gain. So we've sort of talked about that at length. If the weight gain is a menopause issue, then it should help with that. That's going to take a while. Weight gain is a frustrating one. It probably takes the longest to really kick in. We say 3 months, but sometimes it's that second 3 months before you really start seeing the weight. But if this is, a situation where you really never had a problem with weight, and then all of a sudden you kind of hit that age, and now, you look at a French fry and you gain weight, then this should help. If you're someone that's been struggling with weight their whole life, and, that may not be a hormonal issue, at least your female hormones, so it may not have the same impact.
Absolutely. And our next question is from Trisha. And Trisha is wondering, what is the best way to increase energy if you are already on the estriol patches and oral progesterone? She says, I'm exhausted.
Adding DHEA may help. So estrogen and progesterone are main female hormones. But women also need a little bit of testosterone. Now, we think of testosterone as the male hormone because it is the predominant in men. But women need a little bit of testosterone as well. And testosterone is produced by the ovary, and it drops off. So your testosterone levels in your 50s are about half what you were in your 20s. Problem is, you only need a little bit. So it's really easy to overdo it with testosterone. And that's my problem with particular pellets that tend to be very heavy testosterone-based is I see a lot of problems with people getting overdosed with the pellets, and then you're stuck with it for 3 or 4 months, and you have all these terrible testosterone side effects. So testosterone is a tricky drug. It's also what's called a scheduled drug. In other words, it's kind of in that same class as like a narcotic or like a ADHD medicine. And so it's not something that we can prescribe on our telehealth platform. It's also very tricky. And so even if we could do it, I'm not sure that we would, because I'm not sure that we'd be able to do it well. On the other hand, DHEA is a hormone that gets broken down into primarily testosterone, but a little bit of estrogen. But it's the testosterone we use it for it. And so when you take DHEA, it gets broken down within 30 minutes to testosterone, and it will boost your testosterone levels up. And it's testosterone may be the culprit that's causing your energy problems. So the nice thing about DHEA is that in small doses, 25, 50 milligrams, it's enough to get your testosterone back up to those normal female levels without kicking you up to high level causing problems. Now, the problem with DHEA, no, this is not specifically the question we asked, but we use this to educate, is that it's a supplement. So you don't have to get it from us. You can go on Amazon, buy DHEA. The problem is that when people do that, they're not doing it under the guidance of a physician. And so people don't know how to dose it. And DHEA is a performance enhancer drug when used at really high doses. There are people using 200, 400 milligrams a day, and in those doses, you're going to push the testosterone levels to high and cause problems. And so there's a lot of scary warnings about DHEA on the internet. Mayo Clinic website, Cleveland Clinic website have this big scary warnings about DHEA, and probably rightly so, because people don't know. They just get it at the drugstore, they buy it off Amazon, they get a whole bunch of it, and then they have problems. When we prescribe DHEA, we're using very small, relatively small doses, 25, 50 milligrams max, and you're getting it under a physician's guidance. And so those same warnings don't apply because we're doing it correctly. So adding DHEA, all I have to say, adding DHEA may be the key to help you.
Absolutely. And I see this is probably going to be our last question because I'm guessing that's probably a little in-depth, and I see a few people asking this as well. But stick around because we'll have a few things to say after this question. But we have a few people that are wondering, what exactly does progesterone and estrogen and estriol do in my body to help with menopause?
Yeah, that's a great question. Actually, I was kind of thinking of starting with that. So how you guys?
There we go.
So estrogen is the primary hormone for women. It's the important hormone, and there are estrogen receptors in just about every part of the female body. There's a certain level of ideal estrogen that you're supposed to have, and that's produced by the ovaries. What happens is that as you get older, the ovaries become less and less efficient and productive, and efficient is the right word, at making estrogen. And so those estrogen levels start dropping. And as I said before, they don't just drop in a nice, smooth way. The ovary goes down fighting. So it's trying to get this out. So you get these kind of spikes of estrogen. And as I mentioned, the body doesn't like abrupt changes. And so that can cause all kinds of symptoms as you're going through this transition. So there are some symptoms that are really symptoms of the transition period. Hot flashes, night sweats are the most common ones, most obvious ones. And those tend to kind of hit, and they're bad for a while. And then they tend to go away as the ovary kind of finally stops producing hormones at all. So for most women, as they get past menopause a few years, that kind of stuff goes away. But there are other things that estrogen does that are really important for tissues. Heart health, bone health, vaginal health, skin health, hair health, all these other things that don't get better as you complete your menopause transition. They continue to be a problem. And so estrogen can help decrease your cardiovascular risk. It helps with the health of the vagina, as I talked about earlier. Keeps the tissues moist and healthy and receptive. And it can help skin. It can help decrease wrinkles, make skin appear more healthy, can help with hair thickness. So one of the things that happens as estrogen lowers is hair thins. You see older women with thinner hair. Look at pictures of them when they were young, these big, thick head of hair, and that's from estrogen. So estrogen is really the key hormone. And it affects just a wide range of things in the body. So progesterone is also important, but it's not nearly as important as estrogen. It doesn't really help with the symptoms like estrogen does. The one problem with estrogen is that it can stimulate the lining of the uterus. And so, as I said, it works in all these tissues. One of the things it works on is the lining of the uterus. And the lining of the uterus is really meant to have a cycle of estrogen and progesterone. It's supposed to have a balance of these two hormones. Estrogen stimulates the uterine lining, and progesterone helps tone that down and organize it. And so what happens is if you keep the uterine lining under just estrogen, it overstimulates the lining. It can cause problems, something called hyperplasia, which is an overgrowth, and if left unchecked, ultimately can become a uterine cancer. So obviously we don't want that to happen. So in a woman that still has a uterus, if you haven't had a hysterectomy, the progesterone is super important to take along with the estrogen to balance those two hormones at the uterus, at the what we call endometrial level, at the lining of the uterus, to keep it all safe. And in fact, when you take estrogen and progesterone together, your risk of uterine cancer goes down, not up. But if you were to take only estrogen, that risk goes up to be really too high to be comfortable with. So we add progesterone for that reason to the estrogen, but estrogen is really what's giving you the vast majority of the benefits. In fact, if you've had a hysterectomy, the vast majority of women that have had a hysterectomy do not need progesterone. They only need the estrogen because estrogen's going to give them all that extra benefit. And for whatever reason, the progesterone is, and this is backwards of what people think, it's the progesterone that increases the risk of breast cancer, not the estrogen. Estrogen therapy does not increase the risk of breast cancer, which is totally opposite of kind of the common thinking. But the data is pretty clear about that. It's really the progesterone that can do that. Now, the good news is micronized progesterone, the type of progesterone that we use, does not increase that risk in the same way that, for instance, Procara, which was the most common synthetic progesterone that's been used for HRT, does. And then some people think that there's actually maybe a neutral or even slightly protective effect, but we don't have enough data to say that for sure. But generally, it's the progesterone component of HRT that slightly increases the breast cancer risk. So if we can avoid the progesterone, all the better. So if you had a hysterectomy, you really only need the estrogen. You don't need that progesterone. But if you still have a uterus, it's really important. So there's two exceptions, and that is the estriol face cream doesn't get absorbed enough to stimulate the uterus, so that's safe to use with that progesterone. And estrogen vaginal cream really has just a local effect on the tissues of the vagina without overstimulating your uterus. If you're only using an estrogen vaginal cream, it's safe to do that with progesterone. Those are the two caveats. So there's a lot that goes into this. But that's sort of the big picture between estrogen and progesterone. And then DHEA, I already kind of talked about at length about how that works by increasing your testosterone levels a little bit. And so that's how the three hormones that we use at Winona help your body and how they all play together. So estrogen is the big winner. Progesterone keeps the estrogen safe. And that DHEA helps give you just a little bit of a testosterone boost to help with energy, weight loss, issues.
Well, thank you so much, Dr. Green, for going so deep into that. I hope that was really helpful for all the women listening. I know it was really interesting. I think for me, I don't know, I always love getting to hear things explained more than once too, because I think, there's always more things to learn. I'm always a big proponent of lifelong learning and what that looks like, even like it with the health journey and everything with that. But thank you so much to everyone who made the time to be here tonight. We know that sometimes it's a commitment in your schedule in life to carve out the time to be here. So whether you're listening on your phone, whether you're sitting on your laptop, however you've made the time, we're so glad that you're here. We also want to just remind you that if you love these conversations and hearing these questions, we also have our the Menopause Hour podcast on Spotify. And so you can check it out there. This same episode will be uploaded there in a little bit. I know there was a few of you, we didn't quite get to your questions. We would love to get to them. Come next time. We'll try to get to them. Also, message your Winona doctor if you're a Winona patient. They always want to chat with you there. Also, our community is a great place to kind of, chat about your experiences and your journey. So connect in there as well. But we're so glad you're here. And Dr. Green, thank you so much for your time. It's always fun. I feel like you have great stories. You bring the energy, which I think is always really helpful in these because, health conversations can be, hard to have sometimes, but you make it fun.
It's great to be here. And I love to educate.
Well, you're great at it. It's obvious that that's what you were meant to do, Dr. Green. So we're glad to have you for sure. All right. Well, everyone, I hope you have a great rest of your night, wherever you are, wherever you're at, whatever time it is there. I hope you have a great rest of your night. And we will catch you next time. Thanks, everyone. Bye, all.
Thanks for spending time with us. We hope today's conversation helped you feel more informed, more supported, and a lot less alone. If you're ready to go deeper, download the Winona app. It's free, it's for you, and it's filled with resources, real stories, expert insights, and a vibrant space to connect with women navigating the same season. Have questions? Join our next live Q&A. Until next time, take care of yourself. We'll be here when you're ready for more.